On behalf of the Provider Relations team at the University of Iowa Hospitals and Clinics, we thank you for attending today's presentation, The Heartbreak of COVID-19 Across the Ages, with Dr. Ian Law, Pediatric Cardiologist. Our faculty's goal is to share information you can use about the latest therapies and techniques in medicine and answer your questions about how to partner with us in the care of your patients. If you'd like more information or to talk with Dr. Law following this presentation, please reach out to your provider relations liaison or directly to him. These are informational presentations to enhance your clinical practices and to provide you the most updated information we have. No CME credit is provided at this time. This program is being recorded and will be posted to our educational resources for referring physicians webpage. At this time, I'd like to welcome Dr. Law and turn it over to you. Thank you for joining us.
Good morning, and thank you for inviting me to give this talk. Obviously, COVID has penetrated every aspect of the care we provide. And as a pediatric cardiologist, my focus has been on the cardiac effects. And so I was asked to give a talk on the heartbreak of COVID, and someone said, "Well, that's a great title." I said, "Well, I hope that's not the best part of the talk," but here we go. I have no disclosures. However, I think we all recognize early on that the COVID pandemic resulted in a large number of scientific papers coming out, and early in May, there are more than 5,000 research articles per week appearing about COVID. And as one might imagine, keeping up with the literature was a challenge. And as I've given this talk, the content has changed several times because there's so much new information coming out on a weekly basis. So the disclosure is this data may be obsolete by next week. So this is a very broad overview of COVID. We all know that it enters a cell using the ACE2 receptor, enters a cell, gets replicated, and then gets released back out into the body. And it's this release of the virus into the body and the response of the body that causes much of the manifestation of the disease, including the cardiac disease. And you'd think this was the only receptor that's important, but just recently we found out, this goes back to speak about the tsunami of information, that the neuropilin receptor is just as important perhaps as the ACE2 receptor. And it said that it's able to use a receptor called neuropilin-1, which is very abundant in many human cells, including the respiratory tract, blood vessels, and neurons. And so you can see the effect of COVID can be across broad systems and within the body. And I thought this was a very interesting article. They used a supercomputer to analyze data, genetic data from COVID victims or recipients. And they said that COVID is like a burglar who slips into the unlocked second floor window and starts to ransack your house. Once inside, though, they don't just take your stuff. They also throw open all the doors and windows so that accomplices can rush in and pillage more efficiently. And this is the effect it has. It's not just a respiratory illness. It goes throughout the body, and they focused on the bradykinin effects of COVID. So this is going to be something that'll be helpful, and we've all seen these graphs before, but COVID, once you get exposed, you've got this basically incubation period in which you're asymptomatic, and then about, within 4 to 5 days, you start to have an antigen level that's detectable. And that peaks, here's the antigen, the SARS antigen here. And after that, you develop your antibody response. And so this antigen response is important because this is what we will look for in the disease process. And it peaks right around 10 days and starts dropping off again. And it remains at a low level for a period of time as your antibodies go up. But after this period of time, it's felt that you're no longer as infective or can spread the virus here as you are early on when you don't have the antibody response. So with regard to the heart, COVID can have several different effects on the heart, and it can be a primary infection. So this is where the COVID virus comes in and directly infiltrates the heart and gets into the myocardial cells. This is direct viral myocardial invasion. And it turns out this is actually relatively rare. It can actually affect the lungs, of course, which is its primary organ that it attacks. And then just due to the supply and oxygen decrease in oxygen supply, you can get a type 2 myocardial infarction just because of the stress of low oxygen. You can have an inflammatory response from the COVID, and just that inflammatory response can affect the heart. You can have a coronary plaque rupture, which causes a type 1 myocardial infarction. You could have microvascular dysfunction, and you can have just the stress of the disease itself can cause a cardiomyopathy on the heart. So all these different things can occur from the COVID virus that affect the heart. Now, early on in Wuhan, it was noticed that the heart could be affected. And so what they did is they measured high sensitivity troponin. And if that troponin was above the 99th percentile, they considered to be a sign of cardiac injury. And early on, they thought about 20% of the people that were hospitalized had some cardiac manifestation. And they found out if you had cardiac effects of COVID, there was a higher mortality rate. So if you look over here in this initial study, if you had cardiac injury, this is the mortality rate if you had cardiac injury versus no cardiac injury. Then there's another case series, a little bit larger, where they thought the cardiac manifestations was 27% or 28%. And once again, they found a higher mortality rate if you had cardiac involvement versus if you don't. And here's the cardiac involvement versus no cardiac involvement here. And then there's another study later on, almost a couple months later, where they looked at people about 2.5 months after they had the COVID infection. We'll go to this data a little bit later. And they found that cardiac involvement was about 78%. So here you see 2.5 months later, 78% of the patients by cardiac MRI had some cardiac involvement versus those that didn't have cardiac involvement that had a normal cardiac MRI. So cardiac effects from COVID have increased, but depending on how you evaluate them. So once again, the COVID effects, if you have an elevated troponin, what could that be a sign of? Well, it could be a sign of direct injury, but it could be that you just have a chronic congestive heart failure state and you have chronic myocardial injury. So you've got this troponin rise, but it's due to chronic injury. And then you can have this non-ischemic effects, and that's from a primary cardiac illness such as myocarditis, inflammation, stress cardiomyopathy, or acute heart failure. Or you could have other primary cardiac disease, critical illness, sepsis, and pulmonary embolus. These are all things that will cause a troponin rise associated with the COVID virus. And then you have this acute effect, which is the myocardial infarction. This is the type 1 infarct. And the type 2 infarcts, one is a direct effect on the blood flow to the heart. Number 2 is from hypoxia, tachyarrhythmias, hypotension. Now, the question is, what is troponin? And what is high sensitivity troponin? So if you look at this, we all remember the sliding filament theories where the myocardial cells contract and relax due to the sarcomeres. And if you look right here, this is where troponin T is. And this is what we measure in the bloodstream. When you have inflammation, this troponin T gets released into the bloodstream. Now, back in the mid-90s, the troponin measure was not nearly as sensitive. But over the years, we've become much more sensitive. So at the University of Iowa, we use this troponin T, the high sensitivity troponin. And anyone that falls in this category here is called a high sensitivity troponin. Now, the problem is the more sensitive you get, the more likely it is you'll pick up something that isn't necessarily myocardial disease. And we'll go through that just a little bit later. But as you read the literature, you'll find that the levels that they use for cutoffs may vary from 0.01 to 0.1 to 1. And you have to make sure that you keep track of that because you can't compare one study to the next study just based upon the number. So this goes back to discuss the chronic elevation we see of someone who's got congestive heart failure. So if you were to draw a troponin on someone who's got chronic congestive heart failure and maybe had COVID exposure, you may see an elevated troponin. And if you only have one measurement, you may say, well, this is elevated. This is above the 99th percentile, so they have myocardial injury. But what you'll notice if you follow them over time is they've got this chronic injury and you don't see this acute rise. This is at day 0, day 1, day 2, that you'll see if they have a myocardial infarction or some other type of myocardial injury. So one measurement doesn't necessarily tell the story. You have to do serial measurements. And if you have an elevated troponin, it could be a transient ischemic myocardial inflammation, or it could be a non-cardiac cause. And this is the problem with the high sensitivity troponin. You could have a pulmonary embolus, you could have renal failure. And if you have renal failure, that'll cause elevated high sensitivity troponins, sepsis, burns, extreme exertion. And when it goes discussing marathons, what they found is if you run a marathon and you check a troponin, within 24 hours, you'll have a troponin elevation. And it can be comparable to what you see in a non-ST segment elevation myocardial infarction, not as high as what you see with this ST segment myocardial infarction. And this myocarditis is very comparable to myocarditis. So once again, if you draw a troponin on someone who's run a marathon, you'll see elevation. Now, I've run several marathons, and I'm glad I didn't check my troponin. But here it is at 24 hours, you're seeing a peak just like you do with myocarditis, although with myocarditis, it tends to last longer. Now, what's important about this is we're using troponins to evaluate athletes. And so when we evaluate an athlete, if they had a vigorous practice, it may not mean that they've got COVID if they've had a COVID infection. It may mean just they've been very vigorous the day before. Once again, going back to those Wuhan studies, if you look at serial troponins, if you have a serial rise over time, this is 2 weeks out and this is 3 weeks out, if that troponin continues to rise, your mortality rate goes up dramatically. And this is a study that shows the same thing, that shows an increase in troponin shows a much higher mortality rate. So if your troponin's at a very high level, your mortality rate is much higher, nearing 100% at the highest levels. So if you see an increased troponin and a patient has had COVID, you have to suspect myocardial injury. Now the question is, myocardial injury, myocardial inflammation, and myocarditis. And we, in the world of cardiology, throw the word myocarditis around and without abiding to the true definition. So it was early on, they realized that the COVID could affect the heart, but people were calling it myocarditis when it wasn't truly myocarditis. It could have been myocardial inflammation. Only early on, they think it's less than 7% of COVID-related deaths were attributed to myocarditis. And it was assumed not based upon a confirmatory diagnosis. So it may be even been overestimated. And in order to have the diagnosis of myocarditis in a patient who's had COVID, first you have to have inflammatory responses, lymphomonocyte infiltration, and necrosis, not typical of ischemic injury. You have to have if you were to take a sample of the heart, you'd have to find the COVID-19 genome within the cardiac tissue. And ideally, you want to see viral particles within the cardiac myocytes. You have to exclude other known viruses such as enterovirus and parvovirus. So to have a true diagnosis of myocarditis is rare. And now there's a recent study that showed that myocarditis is probably less than 2% of all patients that have the COVID-19 infection. So we have to be cognizant of that. And even as I give this talk, I'll say myocarditis, but really what I mean is myocardial inflammation, because myocarditis myocarditis will cause myocardial inflammation, but myocardial inflammation does not mean you have myocarditis. Myocarditis is a small subset of those patients who have myocardial inflammation. And the diagnosis of myocarditis cannot be based only on troponin elevation, and elevation is often lacking for a true diagnosis of myocarditis. So once again, if you get the SARS virus, it can cause hypoxia, sepsis, systemic inflammation, pulmonary thrombosis, embolism, and stress myocarditis. All those can cause a troponin elevation, and you can also have the type 1 infarct. Myocarditis is a small subset of all these. So we think about the effects of COVID on the heart, but this is an interesting study that shows that the effect of COVID on the heart goes well beyond the pathologic effects we see. And this was a study done in Denver. And what they did is they looked at total EMS runs and cardiac arrests over time. So this is before we had the mandate of the stay-at-home orders and the shelter in place. And you can see the cardiac arrests were relatively low and the EMS runs were higher. And then they had right around the time of the mandate, they said, well, we need to shelter in place. We need to shut down non-essential stores. And here we see that the EMS run starts dropping off and the cardiac arrest goes up. And then after the mandate, we see a dramatic decrease in EMS runs. People are not calling for if they have symptoms, and we're not going to the doctor, and the cardiac arrests go way up. So, and this is just over time, over the years of the cardiac arrests. And you can see in 2020, the number of cardiac arrests dramatically increase. So the two theories is it's possible that the complications of COVID are responsive for this. So maybe it is the stress, the thrombotic events associated with this, the vasculitis, the direct myocardial injury, or it may just be patients with acute coronary syndromes are not presenting for care, resulting in an increase in out-of-hospital cardiac arrest. So this is obviously a non-intended consequence of having the COVID virus pandemic. So as we look at the different tools we can use to evaluate patients who have myocarditis, one of the first ones is the EKG, and we look at the arrhythmias associated with it. So all the arrhythmias that have been documented with COVID include supraventricular tachycardia, AFib, a flutter, complete heart block, cardiac arrest, and then the ventricular arrhythmias. The mechanisms include hypoxia, myocarditis, and this mechanism list will be a common theme throughout this talk. Hypoxia, myocarditis, immune response, myocardial ischemia, myocardial strain, drug effects, and we found this out with hydroxychloroquine. So the management strategies are treat them with supportive care, but make sure that you evaluate the patient for inherited arrhythmia syndrome, such as long QT syndrome, and which could be affected if you give them hydroxychloroquine and other drugs that can cause interactions within the COVID therapy. And also you have to optimize management and evaluate the EP team if you suspect arrhythmias. Arrhythmias are much more common in the critically ill patients. And this just shows you what was in one study in New York, what type of arrhythmias were seen in the non-survivors versus survivors. And so PACs, an intraventricular conduction delay, abnormal QRS axis, myocardial changes, T-wave inversion, AV block, RVH, LVH, repolarization, AFib. These were predictors of non-survivors. The ventricular arrhythmias were there, but they weren't as pronounced as these when trying to distinguish who's a survivor and non-survivor. Heart rate, QTC, PVCs, ST elevation was not as predictive. Now, when you look at this, LVH and RVH are listed as more prominent in patients that are non-survivors. But when you get an EKG in an athlete, one of the things you have to think about is this change in an EKG associated with them being an athlete, or if they've had COVID, is this a change associated with them having COVID? And these are on the left, three are EKG changes that are very common in athletes: sinus bradycardia, first reblock, incomplete right bundle branch block. All of these can commonly be seen. So if you see these in isolation, we don't worry about these. In the middle panel are things that may be a normal variant. And what you see is left axis deviation, right axis deviation, RVH, T-wave inversion. These are things that you'll see if you've had COVID, but there are also things you can see in an athlete. And any one of these in isolation can be normal. If you have two or more of these, it puts you into a more worrisome category. And these are all things, if they're seen even in isolation, have to be evaluated and warrant further testing. This is an example of a patient that I was involved in. And this is ironically, this family lived in New York, and during when New York became an epicenter of the COVID outbreak, the family drove from New York to Iowa, and sure enough, when they got here, she got COVID. And this is her EKG, and what you'll see is she's got these P waves marching through, and she had this increased automaticity. These are P waves that rapidly march through, causing winky block, and she was doing this over and over again. And eventually we had to treat her with antiarrhythmic medication to control this, and we were able to control it with flecainide and sotalol, and she was able to head back to New York. Eventually this resolved on its own, but this was atrial arrhythmia associated with COVID. And these are classic EKG changes. You'll see ST segment elevation in someone who's got a myocardial inflammation, or what many call myocarditis. With regard to echocardiogram and its use in evaluating a patient who's had COVID, in Tel Aviv, they looked at 100 hospitalized patients, and they did echoes within 24 hours of admission if there's some sort of clinical deterioration, which occurred in about 20% of patients. And if you look at the patients that had echoes done, if they had deterioration, a third of them had normal echoes. More than a third of them had right ventricle dilation or right ventricular dysfunction. Left ventricular diastolic dysfunction was less common than right ventricular involvement. And so what they found was that the right side seems to be more affected than the left side, and that may be due to pulmonary embolus or pulmonary disease in general. Now, once again, right ventricular enlargement is not all that uncommon in athletes. And so when you see a patient who's had COVID, an athlete who's had COVID, and they've got an enlarged right ventricle, you have to be able to distinguish between, is this just a training effect, or is this an effect of the COVID virus? And these are just some examples of what we're looking at. This is a normal echo. Here's the left atrium, left ventricle over here, left atrium, left ventricle, and here's the right ventricle. And you can see in this patient, they've got left ventricular enlargement. So you compare this to here, here's a dilated left ventricle. And then in this case, this is the normal right ventricular size, and this is a significantly dilated right ventricle. So there's some images that we might see in a patient who has myocarditis or myocardial inflammation. Here's another image, and I'll just play this one here. This is a patient who came in with myocarditis. You can see this very dilated left ventricle with a poor squeeze. Now, this is going to go through the data they found in the study out of Germany, where they looked at 100 patients who had COVID, and this is looking at a cardiac MRI. And what's nice about the study is they used age match controls and comorbidity match controls. And the reason why this is important is because if you have a patient who's got chronic congestive heart failure, who's got diabetes, who's got a history of an infarct, you want to make sure you can include those in your control groups, because if you do a cardiac MRI in those patients, you may see changes that are not necessarily indicative of a COVID exposure. So these are patients in this top panel that were healthy or had risk factor match controls that had cardiac MRIs. And these are patients that had COVID. These did not require hospitalization. These patients did require hospitalizations. What you notice, and it's not surprising, is that the troponin were elevated, significantly elevated in those patients who had COVID. So that's something we knew from before. But if you look at the cardiac MRIs, what you'll see is that the T1, and these are findings of extracellular volume and fibrosis, were much more elevated in patients who had COVID than those who didn't have COVID. And they're significantly elevated. They didn't see as much of a change in T2, which is more of a sign of edema. But remember, this was 2.5 months out. 80% of the patients had some changes. And this is one of what they'll look at here is they'll look at the cardiac MRI, and they'll take samples of the myocardial tissue, and they'll compare these to normal areas. And if they have changes within these specific areas, it'll help them determine if they've got some myocardial injury, inflammation, scarring. So here's a cardiac MRI, and what you'll see here is this is the left ventricle, this is the right ventricle, and the yellow areas show that this patient had fluid outside the heart, so pericardial infusion, but they also had epicardial intramyocardial enhancement or late gadolinium enhancement. So this is the patient who had COVID, who had both had a pericardial fusion and some late gadolinium enhancement, which could be scarring or poor perfusion areas. This was one case out of that study, and they had an adult male with a myocardial inflammation, but he had very little symptoms early on. So this is a patient who never required hospitalization. He lost taste and smell. He had a mildly increased temperature for 2 days and no known previous cardiac condition, and had no regular medication use. And what you'll see is this is a patient who on MRI had changes, and he had actually myocardial inflammation, not necessarily myocarditis, because you don't see the virus within the myocardial cells, but this was picked up after he had an abnormal MRI almost 2.5 months after he had his COVID infection. So despite having a relatively benign course, he had myocardial involvement. These are more examples of what you might see on a cardiac MRI. And so here's the left ventricle, and you can see these areas that are brighter than the surrounding tissue. And this is on a special sequence. And here's another one right here where they'll find these brighter areas within the myocardial tissue that are signs of inflammation. And once again, cardiac involvement by cardiac MRI in this study in Germany was seen in 78% of COVID-19 patients. Ongoing myocardial inflammation was seen in 60%. And the myocardial inflammation was independent upon pre-existing condition, disease severity, overall course of acute illness, and time from the original diagnosis. So this brought a lot of concern in the medical press that we're just because they get out of the hospital, just because they never came in the hospital, that does not mean they didn't have cardiac involvement. And these are some examples of cardiac MRIs, mainly looking at the function. And so here's an example of the image we're taking. Here's a left ventricle, here's a right ventricle, and here's a very poorly functioning left ventricle that's dilated. Now, in the evaluation of COVID, they've developed special protocols for patients who have COVID-19 that we should focus on to make sure we're not missing things. And so this is just a typical checklist that has been that was proposed back in August, looking at things that should be obtained, the T2 weighted sequences, parameter mapping. And I got to tell you, if you're going to ask me questions about this later on, I'm not the person to answer these questions, other than the fact that when we have our imaging faculty obtain cardiac MRIs on our COVID patients, they use a special protocol so they don't miss subtle changes. Now, once again, when you get a cardiac MRI, just like with EKGs, there can be an overlap between an athlete EKG and a COVID EKG. There can also be changes that are seen post-COVID with dilated RVs and LVs and a normal athlete. So if you look at, these are the ventricular volumes and masses in athletes. And so this is a non-athlete. These are regular athletes, and these are elite athletes. And you'll see it's broken down by men on the top and women on the bottom. And what I'm going to focus on is, this is the left ventricle end diastolic volume for men who are non-athletes. And you can see athletes have an enlarged left ventricle, and elite athletes have an even larger left ventricle in diastole. And same thing for women. At baseline, here's their right ventricular volumes, and here's the left ventricular volumes. And the heart gets bigger as a normal response, physiological response to exercise. But also, we know that the right ventricle and left ventricle can be dilated if you have COVID. So if you do a cardiac MRI on an athlete, you have to be able to recognize that pure diagnosis by your RV or LV enlargement will not necessarily mean they have COVID effects on the heart. Now, with regard to management of COVID, it's been frustrating because there's no clear recommendations for the treatment of myocarditis. The treatment has been supportive for just a COVID infection in general, but this is out of the European Society of Cardiology. And for myocarditis, there's no clear recommendations can be given for a COVID-19 infection. And there's a scarcity of evidence regarding the efficacy and risk of different treatment strategies in patients with COVID-19. So really, we don't have an answer. We treat the COVID infection, but we don't have a great way to treat the myocarditis or myocardial inflammation. And this was out of Lancet. Whatever the reason for apparent declining mortality, the impact of the drug treatments on the COVID-19 pandemic is still limited. The massive research effort needs to bear fruit with broader range of effective therapies. Now, as we all know, we're doing a much better job, and we think that the monoclonal antibodies and the antiviral medications are effective. We're finding that things like hydroxychloroquine are not effective, but there's still much to learn. Now, with regard to pediatrics, fortunately, pediatric disease, especially cardiac disease, is much less severe than adults, and less than 10% of pediatric patients have more than moderate symptoms. Cases of multi-organ involvement are rare, and the mortality rate and the fatality rate is much lower. And we talk about fatality rate, we're talking about the total number of COVID deaths over the total number of COVID cases. And then in pediatric fatality rates, it's the number of pediatric COVID deaths over the number of pediatric COVID cases. The clinical manifestations in children are a little bit different. They tend to have more GI symptoms. The risk factors are less clear, but obesity and severe lung disease has come up as some of the risk factors. The thing we worry about most is the multi-inflammatory syndrome in children, which appears to be more of a significant concern, and I'll cover that. About a month ago, about a month and a half ago now, they were talking about the concerns as children went back to school about the dramatic increase in cases, hospitalizations, and deaths. And they said, well, the 720% increase in cases, 356% increase in hospitalizations, and a 229% increase in deaths. And this is significant. Obviously, we worry about this, but the total number of deaths is really quite low. And if you look at the total number of COVID deaths in children versus the total number of COVID deaths, it's 0.07%. So the overall number of children that are dying from COVID in comparison to the total deaths is really quite low. And the fatality rate is 0.02%. It's obviously still too high, but much smaller than that than we see in the adult population. So going back to MIS.C, how do you make the diagnosis? It's in individuals under 21 years of age. Fever is very common. It's over 95%. And you have to have laboratory evidence of inflammation. And in addition to severe illness requiring multi-systems involvement, cardiac, renal, respiratory, hematologic down the line. And you have to have no other plausible diagnosis. And you have to obviously have a current or past SARS infection. And typically this MIS.C occurs about 4 weeks after they've had their COVID infection. And it's very similar to Kawasaki's disease, but it's not Kawasaki's disease. So this was comparing MIS.C to Kawasaki's disease, and you can see that Kawasaki's disease affects a younger age group versus MIS.C. GI symptoms are much more common in MIS.C. Myocardial dysfunction and myocarditis is much more common in MIS.C versus in Kawasaki's disease, it's much more likely to affect the coronary arteries and less likely to have a primary effect on the myocardial tissue. In MIS.C, pro-BNP and troponins are elevated. And here we see more of the ESR and other inflammatory markers. And platelet counts in MIS.C are usually low. You have thrombocytopenia versus if you have Kawasaki's disease, you have thrombocytosis or elevation in thrombic platelet counts. This was a study that was reported in the New England Journal of Medicine looking at 186 patients who had MIS.C. The average age was about 8.3 years of age. The majority had been previously healthy, and the majority had a positive COVID test by PCR or antibody testing. 88% required hospitalization and on an average of 1 week, and 2% of the patients that had MIS.C died. And what you'll see in this right here is when they looked at the testing, a large portion of them had elevated troponins and pro-BNPs, and actually the troponin was not quite as sensitive as a pro-BNP as a marker of MIS.C. Echoes were commonly performed. A large number of them had normal echoes with a normal cardiac function, but we did see a decrease in function in a smaller percentage of them. Arrhythmias were uncommon. Pressor support was common. ECMO was rare. And these are some findings that were in a different study. They had 32 cases of MIS.C. 9 had suspected myocarditis. They didn't get cardiac MRIs on all of them because the patients didn't want to intubate the patients just for cardiac MRIs if they were younger. So the oldest ones had cardiac MRIs, and you can see on the cardiac MRIs, you had these signs of bright areas within the myocardial tissue suggestive of myocarditis. With regard to therapy for the MIS.C, IVIG and glucocorticosteroids were very commonly used. There was no, this study was not designed to evaluate efficacy of medications in MIS.C, but these were the common treatments used, and there's a big overlap with MIS.C treatment and Kawasaki's disease. In this statement, in this New England Journal of Medicine article, they stated that understanding the pathogenesis of MIS.C will be necessary to inform clinical management and prevention efforts. The study was not designed to evaluate or compare the long-term effectiveness of any therapies, and treatment methods must be informed by whether the organ damage is mediated by ongoing viral replication, in which case you use antiviral agents, or an exuberant host inflammatory response, in which case you use immunomodulating agents, IVIG, and steroids. So now going to myocarditis in the athlete and the return to play, there was an article published early on in September stating that 35% of Penn State of athletes may have myocardial involvement, myocarditis, after COVID infections. And this raised a lot of concern. Now, subsequently, this was disproven. But there were case reports. This was a Nigerian-born basketball player who had been taken to the hospital in Serbia. He'd been playing in Florida for the NCAA, and then he went over to Europe, and he died following a COVID infection, and it was felt that he had a myocardial inflammation or myocarditis. There's another football player in the NCAA that also was felt to have a myocarditis from COVID and died. Now, if you look at the risk of sudden cardiac death in athletes, each year there's between 75 and 150 athletes that die in the US. And this was, if you think about the number of athletes in the US, there's about 8 million high school athletes and about 500,000 NCAA athletes, and a much smaller number of course, pro athletes and semi-pro athletes. So if you look at the total number of deaths, it's relatively low. This is an autopsy study series reported by Barry Marin several years back. And the most common cause of death in athletes is hypertrophic cardiomyopathy. Commotion cordis is a sudden blow to the chest that causes arrhythmias. Myocarditis is a small portion of patients, the cause of death in young athletes. So it's about, you'd say between 5 to 10 per year die of myocarditis. But if COVID truly causes more myocarditis, and this number could go up, which raise concerns in athletes. So early on, they developed these what's called return to play guidelines, and these have changed over time. This is one of the very first ones that was proposed. And they said if you have mild symptoms, everyone should get a troponin, 12-week EKG, a 2-day echo, and consider other testing. Now, the problem with the troponin, as you pointed out, is you can get a troponin, but we don't typically get troponins until they've cleared isolation. We don't go into their homes and draw a troponin. And as we know, the inflammation takes place early on. And so if you draw a troponin on day 1 or day 2, you may see inflammation. But if you draw a troponin on day 14, it is quite likely that you'll have a normal troponin, but that doesn't mean you didn't have inflammation. It's kind of like checking a pregnancy test after the baby's been delivered. The troponin that we're checking may be a sign of ongoing inflammation, but it doesn't mean they didn't have inflammation early on. So following these guidelines, there is a letter published in the Journal of the American Medical Association looking at cardiac MRIs. This is out of Ohio State, and they did 26 athletes that had COVID, did MRIs on all of them, and they found that 15% had a cardiac MRI finding suggestive myocarditis, and 30% of them had late gadolinium enhancement suggestive prior myocardial injury. And their conclusion was cardiac MRI may provide an excellent risk stratification assessment for myocarditis in athletes who have recovered from COVID to guide safe competition. And this raised a lot of concern, saying, how are we going to let athletes return to play after they had COVID without a thorough evaluation? So they said everyone needs a cardiac MRI. Shortly after that, the society, several societies in radiology and other imaging groups said, we are a group of clinicians, researchers, and imaging specialists concerned about the presentation, interpretation, and media coverage of the role of cardiac magnetic resonance imaging in the management of asymptomatic patients recovered from COVID. In light of our society's standing in the community and advocacy against low yield testing and low value medical care, we request that you offer clear guidance discouraging cardiac MRI screening for COVID-related cardiac heart abnormalities in asymptomatic members of society. So here you have two diametrically opposed approaches. One is saying athletes that get COVID, regardless of symptoms, need cardiac MRIs, and the society is saying we shouldn't be doing cardiac MRIs on asymptomatic patients. So how do we approach that? Well, these are different return to play algorithms, and here's one for pediatrics. And they said, you know what, all they need is an EKG to return to participation. This was published, I think, in late June, early July. If you're over age 12, just get an EKG. If it's normal, clear them for participation. Here's one from the American Academy of Pediatrics. They said those with moderate symptoms may return to play if they're asymptomatic for 14 days and they obtain clearance from their primary care provider. An EKG could be obtained if there's cardiac symptoms, maybe palpitations, chest pain, shortness of breath, or if they've had COVID with prolonged fever. So they're not even recommending EKG unless you have cardiac symptoms. Here's another algorithm that just came out, and they said if you're under age 15, rest, but testing is unnecessary, not even an EKG. If you're over 15, you go to what's called the college approach, which is shown here. If you're asymptomatic, no testing. Mild symptoms, you can consider testing, but in general, not recommended. If you have moderate symptoms, then you do the EKG, troponin, echocardiogram, and if it's abnormal, consider cardiac MRI. If you have severe symptoms, you have to do the full evaluation. So here's a dramatic change, your differences in the different approaches. Now, this is the most recent algorithm that's been written. So what do you do in the Big Ten? Well, after that article came out of Ohio State, about 5 days later, the Big Ten said, we can return to football, but all COVID-19 positive athletes will have to undergo comprehensive cardiac testing, including troponin, EKG, echo, and cardiac MRI. And you have to receive clearance from a cardiologist. So at the University of Iowa, I have to evaluate every patient who's had COVID for cardiac involvement. And then it talks about the earliest you can return to play is 21 days after you've had a COVID infection. The high contact sports, which is a different definition than we typically think about. The high contact sports are football, basketball, cheerleading, field hockey, lacrosse, rowing, soccer, water polo. These are ones where the athletes are very close to each other, and breathing heavy, and have a higher likelihood of transmitting the virus from one person to the next. Low contact sports are golf, fencing, rivalry, swimming and diving, track and field. So it's a different concept of high contact sport being football, whereas this is high contact because of viral spread. So this is the Big Ten protocol. Early on, we provide education to talk to the athletes about social distancing, wearing a mask, making good choices. We do screening, and in football, we screen the athletes every day. So every day they get a rapid antigen test, and if it's positive, they get a confirmatory PCR test. So thus far in the Big Ten, we've performed over 100,000 PCR tests. Now, because we're testing every player, there's 170 tests per team. We're testing every day, and we've been doing this since back in August. If they get identified as having COVID, they go into isolation. They get an evaluation, cardiac evaluation after isolation, which includes the high sensitivity troponin, echo, cardiac MRI, and these are adjudicated by several different imaging faculty, or for the EKGs are read by two physicians. We manage them if they have symptoms. Most of them are, the majority that I've seen have been cleared. They return to play. They get education about making good choices. If they get symptoms again, they get retested. And we've had several patients who've had COVID again, and they go back to this process. Now, as part of the Big Ten registry, we're also required to monitor the data we collect. So all this data that we get from the troponin, EKG, echo, and cardiac MRI, we put into a Big Ten registry. And it is our hope that we'll get a better idea of, depending on whether their symptoms were moderate, severe, asymptomatic, if we can better predict who will have myocarditis and what tests are necessary. And it's my suspicion, I highly suspect that we will not need cardiac MRIs in all these patients. We're just to the point of collecting this data, but as we get this data, it's my hope that we will be able to determine which tests are necessary and which ones are unnecessary. And maybe we need to determine that we need to check troponins earlier on in the disease process. If you have myocarditis picked up by the testing methods, you are restricted from sports, competition, and practice for no less than 3 months and up to 6 months after initial illness. So it's a big deal if you think you have myocarditis. So what are the take-home message? COVID can affect the heart due to multiple mechanisms. Troponin is an important biomarker associated with worse prognosis. Cardiac injury can persist after symptom resolution, and longitudinal follow-up is necessary. You know, if we just think back to that study in Germany where almost 80% of the patients 2.5 months out were still having some cardiac effects as determined by cardiac MRI. Fortunately, cardiac involvement in pediatrics is less common and death is rare. MIS.C is more prevalent in children. It's similar to Kawasaki's, but it's not Kawasaki's. Treatment for COVID-related cardiac disease is evolving, and we really don't have a set protocol in these patients. The return to play recommendations are a moving target, but significant myocardial injury warrants restriction. Just we said, if you have myocarditis, it's 3 months of restriction. And we have a lot to learn about the cardiac diagnosis and management of athletes. So based upon that, and I've probably gone over in my talk because I get a little overly exuberant about this topic. Do we have any questions?
Hi, Dr. Laws. I have a question for you. If a patient is not cleared to play due to significant myocardial infarction, how long should you wait to retest? I know you said they could be out for 3 to 6 months, but when should you do a second run of test?
Right, so that's a good question. So if you look at, we've evaluated almost 90 athletes at the University of Iowa now, and that's on the full protocol. So to clarify that, after September 16th, or let's say you get COVID on September 15th, you're not required to go through the whole cardiac protocol of troponin, EKG, echo, cardiac MRI. But if you had symptoms and you had positive COVID tests on September 16th, you go through the whole protocol. Now, one could argue, you know, what's the difference between September 15th and September 16th, other than the regulations changed? The subsequent workup is dependent upon what we found on the initial testing. So if we find an abnormal EKG, we see maybe some PVCs or PACs, we do an exercise treadmill test. If it's if we saw some decreased function but nothing else abnormal on cardiac MRI, I'll do a follow-up echocardiogram. I just saw a patient yesterday morning who had a mildly depressed LV function, and we did a cardiac subsequent echo, and that was fine. For 3 months, we do not do repeat COVID testing, and then after 3 months, they go back into the testing protocol. So with regard to just screening for COVID by antigen testing, we do that. We start that up again after 3 months. So does that answer your question?
Yes, thank you.
Okay.
There's another question too. Do you think that after you have all the data from the Big Ten registry, any kind of protocols for pre-participation might be implemented, kind of in the same way that concussions have evolved over the last 20 years with all the baseline testing?
That's an excellent question, because in general, it's very controversial about whether you should get an EKG on every athlete or you should get an echo on every athlete. And then, you know, I've debated this at the national level. And in general, I think we're EKG screening for cardiac disease just broadly is of lesser value. Although this year, when I see an EKG change on an athlete, I think to myself, boy, it would be great to have an EKG beforehand so I can do a comparison were these ST segment elevation changes, were they seen pre-COVID? And so, you know, if I could go back in time, this year, I would get an EKG on the NCAA athletes. But the topic of whether we should get an EKG on every NCAA athlete, as we said, there's 500,000 NCAA athletes. There are 8 million high school athletes. To get EKGs on those athletes would be a logistic nightmare. And then you say, okay, do we only test the athletes? Do we ignore the people that participate in orchestra and band and drama and you know, show choir? You know, we could argue that we need to test all those people. Well, there's 60 million children and young adults between the age of 12 and 25. So if we had to do 60 million EKGs every year to evaluate for cardiac disease, that would be nearly impossible. I did the math on how long it would take if you had just a pediatric arrhythmia specialist doctors to read those EKGs. It would take about 1.5 years for us to read all these EKGs. If we read an EKG every minute for 8 hours a day, it takes us 1.5 years to read 60 million EKGs. So that would be a challenge.
Yeah, certainly.
Yeah. Any other questions?
Yeah, one other one. As the vaccines begin to roll out here in the United States in the next month or two, the pediatric patient and young athletes are a little down on, I would say, lower on the list of priority for the vaccine. Is this going to have an effect on return to play for a lot of these high school and college athletes?
Yeah, if you talk to the college athletes, they all want the vaccine because they don't want to have to deal with this anymore. Actually, I'd say not all, the majority. As they come in to get their COVID testing, I encourage them all to get influenza vaccines. That's not been universally accepted. But most of them don't want to be pulled out of sports, and they know if they get COVID, they're out for 3 weeks. So they're much more likely to get the COVID vaccine. Of course, they'll be lower on the list. And I tell them it's more important that your grandmother gets the vaccine than you get the vaccine. I think probably the biggest effect that it'll have on the vaccine is we'll have fans in the stands more than the athletes getting the vaccine first. Obviously, I think as we all know, the vaccine will not roll out to the general public until late spring, early summer. I don't think that Iowa athletes or Big Ten athletes should be the first to receive the vaccine by any stretch, because in general, they're in a lower risk category. So it's a good question.
All right, I think that is all the questions for today. We really thank you so much. This has been fantastic and so informative. And if anyone watching does have further questions for Dr. Law, then we highly encourage you to reach out to Dr. Law or your provider relations manager, and our contact information along with his will be sent out, so that if you do have follow-up questions, we highly encourage that. So with that, I will let everybody go. And again, thank you, Dr. Law, and everybody have a great day.
Thank you. Have a great day.